Good evening and welcome to the University of Tasmania's Island of Ideas public talk series. My name is Professor Graham Zosky and I'm the Deputy Vice-Chancellor Health at the University. I would like to extend a warm welcome to everyone here in the Stanley Burbury Theatre and to all you tuning in online, and recognise our many donors and supporters who are joining us here this evening. I'm absolutely delighted to host this evening's event, Staying Well in a Struggling System. I begin by acknowledging that we meet in Lutruwita, Tasmania, the sovereign lands of the Palawa people, as we gather in Nipaluna, Hobart, beneath Kunanyi, Mount Wellington, and talk about our health systems. I reflect on the Palawa people's deep history of storytelling, knowledge sharing, and particularly their care for country and community. Health is not the treatment of disease, but the balance of community, country, and spirit, a way of living where prevention and sustainability are embedded in daily life. As we turn tonight to the question of how Tasmanians can stay well in a struggling health system, I recognise Indigenous knowledges and wisdoms about systems of health that have endured far longer than post-invasion models, knowledges that evolve and are deeply held by the Aboriginal community. I pay my deep respect to elders past, present, and to the old people and to members of the Aboriginal community joining us today. In that context, the Island of Ideas series reflects the university's commitment to fostering conversations that matter, the kinds of discussions that ask us to think differently, to listen closely, and to act with care. Australia's health system is under pressure. I'm sure we're all familiar with the public dialogue. Our population is ageing, chronic conditions are becoming more common, emergency demand is persistent, and inequity still has far too great an impact on health and wellbeing. The result is a persistent climb in healthcare costs, consuming more than 30% of the Tasmanian state budget. But health isn't only made in hospitals. Research from our universities shows it is shaped in daily life, in our homes, in our communities, and in the environment. Long before a clinic visit, these forces are setting the course of our wellbeing. If we talk about health only in beds, budgets, GP access, and waiting lists, we miss an opportunity. By the same token, if we only focus on prevention, we risk skipping the tough questions about how we prioritise care. Still, prevention is the part of the system that struggles most for funding, attention, and political will. So tonight's conversation is about a shift in perspective, not just how we respond to illness once it arrives, but how we create the conditions for health in the first place. To start the conversation, we have gathered three experts to ask how prevention can be understood, resourced, and put to work in a way that makes a real difference. With that in mind, it is my absolute pleasure to introduce our first speaker, Professor Verity Cleland. Verity is a behavioural epidemiologist whose research examines how physical activity is shaped by the places we live, work, and play. She has published more than 100 peer-review articles, secured over $8.5 million in funding, and serves as chair of both the Tasmanian Active Living Coalition and the Tasmanian Premier's Health and Wellbeing Advisory Council. Her work has been central in showing how the environments around us, our streets, schools, and workplaces can shape our daily behaviours and health outcomes. Please welcome Professor Verity Cleland.
So now that everyone's comfortably seated and in out of that horrible weather outside, I'd really like you all to stand up, please. Okay, so I'm going to ask you to sit down keep standing if you have a car. So don't overthink that. Just if you have a car, keep standing. Right, so most people have a car. Keep standing if you take your car for servicing regularly. So if you don't service your car regularly, you can sit down. All right, so most people have a car, most people service their car regularly. We invest quite a bit of money in our cars to keep them running. We change the tyres, the spark plugs. We might even give it a wash on the odd occasion. You can sit down now and you can thank me later for that. So breaking up your sedentary time is actually really good for preventing cardiometabolic disease. So you're welcome. So the analogy with the car is an old one, but a really good one. So our bodies and our minds are a bit like our car, and we want to be the guy on the right. So for those who are listening online, this guy's pumping the fist. He's really happy because he services his car regularly and it gets him to where he needs to go. It enables him to live his life in the way that he wants to and do the things that he is able to do. We don't want to be like the guy on the left, right? So he doesn't regularly service his car and it's unreliable, it breaks down, and often it has been known to break down on the Tasman Bridge in peak hour traffic. So we don't want to be like the guy on the left, we want to be the guy on the right. So we need to look after our bodies and minds so that they can do what we need them to do and what we want them to do. So we're going to talk about prevention tonight, and this is a really favourite topic of mine. But we first need to define prevention. And while that may sound a little boring, it's really important so that we're all on the same wavelength in this room tonight. But it's also really important broadly because if we don't define prevention, we can't measure it and we can't monitor it and we can't evaluate it. And that's really important in knowing whether the things that we are doing to try and prevent disease and poor health are actually working. So it is really important to define prevention. So the definition that I like, there are many out there, but the one I'm going to use tonight is any action that keeps people healthy and avoids the risk of ill health or preventable death or premature death. Prevention can be classified in a couple of ways, and the first thing that I'm going to talk about is represented on the slide. So it's whether it focuses on the whole population, and that's on the left, or whether it focuses on specific subgroups. So some approaches to prevention are one size fits all, benefit everyone equally, and try and improve the health of the whole population or avoid becoming unwell. Sometimes prevention focuses on specific subgroups, and that's because we often call them priority population groups, need some additional help. They may face additional barriers to being as well as they can be. And I'm sure you can all think of some groups, those experiencing socioeconomic disadvantage, people living in remote or rural areas, those from culturally and linguistically diverse backgrounds, First Nations people, etc. The goal of prevention is really to maintain and improve the health and well-being of the whole population, while at the same time reducing the health disparities between priority populations and the general population. So we're trying to bring everyone into the same place. So the other part of defining prevention is different levels of prevention. And you can see on this slide that we have a range of levels of prevention from primordial through to primary, secondary and tertiary prevention. And these generally correspond to stages or states of disease and wellness. So I'm going to talk you through a bit of an example from the research that I do, which is focused on physical activity and examining how we can incorporate more physical activity into our lives. So the first picture there represents what we call primordial prevention. And this is about, there's really upstream factors that can influence our behaviour. So in this case, it's the provision of cycling infrastructure. It's separated from the road. It's clearly marked and clearly delineated. People will feel safe using that cycling infrastructure, and it will encourage them to leave the car at home. It's good for our environment. It's good for traffic congestion. It's good for road safety, and it's good for their health through that physical activity. But this is an example of primordial prevention where we may be changing the environment or the policy to try and support people to undertake healthy behaviours. Primary prevention is exemplified here through a walking school bus. For those that haven't heard of a walking school bus, it is what it suggests. It's usually where a responsible adult collects children on the way to school. It's often formal, but it's not always formal. I'm sure I did one of these in the 80s, but it wasn't called that. It was just my mate's mum from up the road used to walk us to school. And these children are generally healthy, right? So what we're trying to do is encourage healthy behaviours through this walking bus program that enables them to live their best lives and tries to prevent them from becoming unwell in the first place. Secondary prevention, this is where we start to intersect with the health system and where we start to see signs of ill health. So the example here is we've gone to the GP and our friendly general practitioner has told us that we have either high blood pressure, high cholesterol, we're a little overweight, and suggests, why don't you get down to your local community exercise program. There's a great one here in beautiful Bellerive, and they're really going to support you to try and manage those risk factors. So whether it's bringing down the blood pressure, helping with weight management, or otherwise, because we're trying to prevent you from that disease, that risk factor from progressing to a disease state. And finally, when we talk about tertiary prevention, this is often when someone has experienced a disease or an event, and in this case, a heart attack. So some people in the room may have been to a cardiac rehabilitation program or know someone that has. And this is where our medical specialist has said, you've had a serious condition. We want you to go and do some supervised exercise training that's specifically tailored for you and your condition. And this is a great example of tertiary prevention because we're wanting to avoid that person's condition getting worse or it happening again. So they're the two key things with prevention: those whole of population, priority populations, and the different levels of prevention. So why focus on prevention of chronic diseases? So when I'm talking about chronic diseases, they're the opposite of what we call infectious diseases, so things like COVID and flu. So chronic diseases are actually responsible for over 90% of deaths in Australia. There are nearly half of all Australian adults have at least one chronic disease, so they're very common and widespread. And around half of all, this is yucky terminology, but it's not my wording. It comes from, I think, the federal government, potentially preventable hospitalisations. Chronic disease is responsible for about half of those. And you can see that's really costly, not only to our healthcare system, but clearly to the people that are experiencing those or living with those chronic conditions as well, and their families. So there are a whole range of chronic diseases that are preventable, chronic diseases. And I've just put up a couple of examples here of some really common ones and ones I'm sure you're all familiar with. Heart disease is the leading cause of death in Australia, and around 70% of heart disease is actually preventable. 1 in 4 people will experience a stroke. It's around 80% preventable. 2 million Australians have pre-diabetes, so that stage where your blood sugar levels are a bit high, you haven't yet got a formal diagnosis of diabetes. We actually know that we can prevent about 60% of those from articulating to a diabetic state. Cancer has a strong genetic component, but we know that 1 in every 2 Australians will be affected at some stage in their life, and around a third of cancers are preventable. So why isn't prevention prioritised? And I'm sure you'll hear some other thoughts from my colleagues, Michelle and Martin, tonight. There are a number of reasons. Some of them relate to lack of clarity and transparency about what prevention is. And that's why it's really important to define prevention, as I mentioned at the start. Who does it? Whose budget does it come out of? Who's responsible for it? Who sees the benefits? Often also there is a really large initial investment, and the returns, particularly with something like heart disease and cancer, are often not seen for decades. So there's this big outlay, really long lag time till we actually see those benefits. And sometimes the benefits might not accrue to the person that invested in the preventive activity. So if we're talking about that cycling infrastructure that I showed you, that might have been implemented by the Department of Infrastructure. They don't see the health benefits. The health benefits will go, to the health system. So there's sometimes a bit of a mismatch between the investor and the beneficiary. Also, political and budget cycles are relatively short term, and we know that prevention is a long game. The other part about chronic disease prevention is that it's complex. Chronic diseases are complex. They are shaped by many factors. And I really like this diagram here for those just listening online. We have a tree, but you can see all the roots showing the different underlying causes of chronic disease. And they range from social and environmental to commercial and structural determinants. And I'm going to show you an example of what this might look like on the next couple of slides. So we have a disease we're all familiar with, heart disease. Some of the biomedical determinants or causes of disease: high blood pressure, high cholesterol, overweight and obesity. These are shaped by 4 pretty common risk factors or risk behaviours: smoking, inactivity, poor diets, and excessive alcohol use. And we know these can be shaped by those upstream structural, environmental and commercial factors. So legislation around tobacco sales and plain packaging, through planning and infrastructure that we've already spoken about, through the procurement of healthy foods and advertising of unhealthy foods, particularly to children, and with alcohol around licensing and taxation. So you can see that even just from this one example, there are really, and I haven't focused on all the different underlying factors, there's a lot of complexity in how we go about preventing a disease like heart disease. Okay, so who's responsible for prevention? I like to say we all are. I think prevention really touches just about every sector and every corner of government and society. I've mapped this here in this slide against those different levels of prevention. So if we're thinking about that primordial prevention, the really upstream factors, we've got all levels of government there. Local, state and federal need to play a role in prevention at that level. And often it's not the healthcare system. It's actually those outside of the healthcare system that have a really important role to play in shaping the way that people behave and their health outcomes. So everything from planning and infrastructure to public transport, education, housing, employment, and the environment. In terms of primary prevention, again, all levels of government do play a role and have responsibility for primary prevention. We often see not-for-profit organisations like the Heart Foundation who run walking programs in the community, other community organisations, neighbourhood houses, and various settings like schools and workplaces have a responsibility there. In terms of secondary prevention, where we touch on the healthcare system, we might find our general practitioner plays a key role here, our allied health professionals, and as we move into tertiary prevention, our hospitals and medical specialists play a role. We also all play a role, all of us as individuals. And so I'd just make a call to action for everyone here tonight. There are things that you can also do. So one, reflect on your own behaviours and attitudes and motivations and have a think about what's driving you and your lifestyle. Social support is really, really important in promoting and supporting others to be healthy. So, support your family and friends and colleagues, encourage them to undertake healthy behaviours. Analyse your environment. So we've talked about how the environment can shape our behaviour. If there's something in your community that's really hindering you from being able to do the things that you want to do and you know that they're really going to help you in your health and well-being, speak out. Get in touch with your local representative or your elected member, talk to the media, do some advocacy. It can be really powerful, and we've seen some great examples of that in our research where people have been able to create change in their local environment through advocacy. And finally, have your say as well. So the Tasmanian government at the moment are developing a 20-year preventive health strategy, which is 20 years. That's a long time, and it's very exciting, but they're consulting this year about that. So, jump on and get involved if you have the opportunity to do so.
Thank you very much, Verity. And that was a lovely presentation and a really impressive arc from starting with an analogy about cars and how they represent health self-efficacy all the way to a big call to action for everyone. Our next speaker is Professor Martin Henscher, a health economist and the Henry Baldwin Professorial Research Fellow in Health System Sustainability at the Menzies Institute for Medical Research. Martin has spent much of his career working in government before moving into academia, where he now examines how health systems can be made more sustainable, not just economically, but also environmentally and socially. His research spans from the immediate costs of air pollution to the long-term consequences of funding choices and how healthcare might function in a slower growth, climate-affected future. Please welcome Professor Martin Henscher.
Thank you, Graham. Good evening, everybody. Tonight, clearly we're focusing on prevention, but and I'm going to return to that, but it's really important that we're clear that there's many other factors which are also driving the many problems that our health system is facing. We have factors like the problems of recruiting and retaining a healthcare workforce, a workforce which is actually aging, a workforce which is experiencing high levels of burnout and sickness, and a workforce which is really heavily dependent on migration. We face very fragile supply chains for so much of the medical products that we rely on in our system. And those already fragile supply chains are getting even more fragile in an increasingly volatile geopolitical world. Our population is aging. We have a generalized mental health crisis. We have continuing direct impacts of COVID, the post-acute sequelae of COVID, and we're beginning now to see the signal of the health impacts of climate change starting to impact on our populations. All while governments, particularly our state government, faces very challenging financial positions, has, let us say, competing expenditure priorities, and something which we don't focus enough on, an increasingly dysfunctional private healthcare system. All of those factors are big drivers of the challenges that our health system is facing. And what's really striking to me is that these pressures are actually being experienced almost everywhere. People often think, oh, the Tasmanian health system, it's so terrible. This is happening in almost every high-income country. Most high-income countries may not have exactly that same menu of problems, but they've got most of them, and all countries are now really starting to struggle. And that is not something that I would have said to you 10 years ago. However, it clearly is the case that failure to prevent disease is not going to help us, and doing better with prevention might be a really important part of the solution, or at least part way to a solution of some of our system's woes. So I'm going to talk about what prevention costs us and who pays for it. Think a little bit about some of the economic reasons of why doing prevention well is hard, and then think about what are some of the things we might need to do a little bit better. If there's a gold standard for spending on preventing illness, this gentleman, Brian Johnson, is probably the gold standard. Hands up who's seen Brian Johnson on Netflix or some similar thing. A few of you, okay. So Brian Johnson's a fascinating chap. So he's a kind of Silicon Valley tech bro. He made a great fortune with a company that he then sold. And he has now devotes his life, quite literally, if you watch this show, it seems to be his every waking moment, to being as healthy as he can be in order not to die. So his goal is to not die. And reportedly, he spends about $2 million annually on his personal, what he calls his don't die longevity protocol. That's about 3 million Australian dollars. So if you put that in context, in Australia, in 2023, we spent $252 billion on our entire healthcare system, public and private. And that's about $9,600 per person. So if we were really serious about prevention and we wanted to spend at the Brian Johnson level, we could afford 83,000 Brian Johnsons in Australia, as long as the other 27 million of us went completely without any healthcare. So that's probably not where we're going to go. So what do we actually spend on prevention in Australia? So the latest data that we have, which comes from 2022-23, says that across the Commonwealth and state and territory governments, we spent $5.8 billion on prevention, or 2,300 Bryans, as my new unit of measuring preventive health expenditure would be. The good news is that was up from 2% in 2018. The bad news is that is definitely not on the trajectory to the 5% target for preventive spending by 2030, which was set a few years ago. And compared to our peers, we're actually not a big spender on prevention. A lot of our peer countries in the OECD spend proportionately quite a bit more than us. We're 27th in the world as a share of total health spending. Although it should be noted, we're not 27th in the world in terms of life expectancy and most of our health outcomes. So we won't go down the rabbit hole of that. That's what we spend on prevention. And spending is one kind of cost. But another way to think about this is, what is the economic cost of failing to prevent illness in Australia? And there's a couple of ways that we might think about this. Verity mentioned this measure, which is called potentially preventable hospitalizations. It's a very simple idea. Those people who ended up in hospital who had a disease that could potentially, reasonably have been prevented. So about 6% of all hospital admissions are potentially preventable, or about 9% of all hospital bed days. And in some ways, the bed days is more important. So 9% of our hospital beds are occupied by people who their condition could have potentially have been prevented. And very crudely, that suggests that those potentially preventable hospitalizations might cost us between $6 and $9 billion a year. So that's already more than we're spending on doing the prevention. Another way of thinking about the cost of failing to prevent illness is, how might it impact on the wider economy? How might it affect productivity? So a former colleague of mine, Jaithri Ananthapavan at Deakin University, did a big piece of work some years ago, and their estimates were that the productivity losses to the wider economy of some key preventable risk factors are like this. Obesity causes productivity losses of $15 billion a year. Alcohol, $7 billion in productivity losses. Physical inactivity, $16 billion. So starting to be really quite big numbers. But if we take one more step back to look at the whole economy, we can think about another concept, which is called negative consumption externalities. So externalities are a very complicated economics way of saying, sometimes when you have a transaction between a buyer and a seller, sometimes there are costs, damages, harms, which fall on other people and not on the buyer and the seller. And the classic and the simplest example of that is pollution. So somebody owns a factory that sells washing machines. I buy the washing machine. Our transaction and the cost of me buying and selling the washing machine does not include all of the pollution of the coal that is being burned to power the factory, of whatever horrible effluents are being dumped into the river, etc. That pollution is a negative externality. And when we start to think about all the negative externalities that are happening across the economy, all of the harms that come along with all of the benefits of all the things we consume, then we start to get to really big numbers. Nobody's done this analysis for Australia, but in the UK, this is using older data, so maybe 2011 data, but some researchers there estimated what are the costs of these negative consumption externalities, what they described as the health externalities arising from modern lifestyles in the UK. So things like avoidable mental ill health, obesity, physical inactivity, all the sorts of things we've been talking about. They came to the conclusion that 38% of all National Health Service spending was a result of fixing up these negative consumption externalities. And that for the whole economy, all of the harms and damages that they were causing was 18% of British gross domestic product. So perhaps a better question than who pays for prevention is who pays for the consequences of not preventing ill health, and who does not pay for the health consequences of the health damage that they are causing. And that brings us to a really important concept, which has been gaining traction in the world of economics in recent years, which is an idea called failure demand. And that is this idea that particularly in terms of public spending and public services, so healthcare, but all kinds of other services like justice and all sorts of services that we rely on, are actually spending a lot of their time and money fixing up problems which could have been prevented in the first place. So demand, that is the consequence of a failure to prevent and do things right in the first place. So those negative consumption externalities drive all kinds of preventable health harms. Those health harms drive people into the healthcare system. It makes them sick and they require healthcare quite reasonably. But then if we're not careful, and unfortunately sometimes we're not as careful as we could be, then we can actually cause more harm to people through poor quality care, causes further injury and ill health, requiring more healthcare to fix that up. And people can start to get stuck in a bit of a cycle, a spiral. And at the same time, we're quite good sometimes at giving people care that they didn't really need in the first place. So low value care, which perversely also exposes them to some risk of things going wrong. So we can get caught in this horrible loop of failure demand. And we also have to be careful when we talk about prevention, that before long, we get into a gray zone of what's prevention, what is early diagnosis. And if we go too far, sometimes we can be at risk of over-medicalizing people. So we have to be very careful. Now, what Verity was talking about, primordial prevention, primary prevention, very low risk of medicalizing people with that. But as we push further into the healthcare system, having to do secondary and tertiary prevention, things can get murkier. So we just have to hold some of those tensions. And a fantastic example of where this is a risk, I'm not saying for sure that this is the problem, but is the explosion with the GLP-1 agonists that we're using for obesity. We're very early in that journey. It'll be really interesting to see, were these the magic bullet that stopped obesity, or actually were they a massive further ratchet in medicalizing people? And we don't know yet. We really don't know. So Verity touched on the fact that decision-making about prevention is quite hard. I'm going to come at that from a kind of financial and policy perspective. There's a few key reasons why it's so hard to do prevention well. Firstly, is the fragmentation and complexity of particularly the Australian healthcare system. It is really complicated and highly diffused responsibility across many, many actors with competing priorities. There's fragmentation across governments, the Commonwealth government, the states and territories, local governments are involved, and beyond the health sector, as Verity talked about, complex interactions of different departments and different agencies having to get involved. And that can lead to all kinds of misaligned incentives. Good economist word. As Verity said, the benefits and the costs might well accrue to different actors. Sometimes the time horizons of prevention are complicated. Clearly, preventing cancer or heart disease might happen on a time scale of possibly decades. But I put the counter argument, some prevention gets very quick wins. So there's extraordinary evidence from China where they introduced, or when they introduced, much stricter air pollution regulations, that sometimes they were seeing decreases in emergency department visits and hospitalizations within weeks of clean air regulations coming in. So not everything, the excuse that this is all way out in the future is not always tenable, but it is a complexity, certainly. I think the biggest problem with prevention, particularly within the healthcare sector, is a very awkward problem, which is that your saving was my income. So we actually can experience the problem, and I'm not imputing any ill will to anybody here, genuinely, but people who treat a disease that gets prevented don't have an income stream anymore. And there is a lot of complexity in there. We've seen things change. So not so much because of prevention, but we've seen cardiac surgery go from a really quite large, high prestige specialty to shrink dramatically, not so much because of prevention, but because the cardiologists got in there with interventional technologies and can now do most of the things cardiac surgeons could do without opening you up. You have incredible changes in medicine, and prevention can be part of that. And we shouldn't underestimate the power of those interests and those incentives. And finally, back to those negative consumption externalities, you can think of your own negative consumption externalities, most of them attached to very large corporations who are very rich, do not wish to see their profits reduced, and are extremely powerful in our political system and in other people's political systems. So we have real challenges in making real traction in some of those areas. So lots in there. Recently, we heard quite a bit about prevention from the Productivity Commission. You remember the Productivity Roundtable a whole 2 weeks ago, talking about one of their suggestions is to introduce a national framework to support decision-making about government investment in prevention, reducing some of those fragmentation problems, improving the quality of assessment, helping governments, all Australian governments, to use the same kind of criteria and analyses, etc. It's a really good idea. Definitely gets a tick from me. But framing prevention in terms of productivity, firstly, is quite a partial solution, but it's actually, interestingly, one of the oldest motivations for government intervention in health prevention. So in 1904, the British government was in a major panic because when they'd been trying to recruit soldiers for the Boer War, they had discovered that up to 50% of potential recruits from working class urban areas could not pass the basic fitness and health requirements in 1903 when they were doing those assessments. And that led to a big report, which was really the beginnings of aspects of the welfare state, and particularly thinking about prevention. So we've been talking about this kind of productivity. We want healthy workers, stroke actually soldiers frequently. And we've been talking about that for a long time. But I'd also say one risk of sticking with the productivity argument is that it keeps us also in the other thing they were talking about at the Productivity Roundtable, which is the war on red tape mentality, that actually what we need is more deregulation. And I would contend that that's completely the wrong way around, unfortunately. What we have to do to get really effective prevention is deal with these negative consumption externalities. And unfortunately, the only way we do that is by challenging industries with effective regulation, really effective policies, and really acting to stop them selling us stuff which harms us. You don't do that by getting rid of red tape. You do that by having really effective government intervention. And if we can't deal with that tsunami of externalities, we can spend as much as we want on prevention, but it will all get washed away. What we need to do is align everything we're doing outside the health sector, within the health sector, line it all up and make it all work together. And that kind of whole systems approach is what Michelle is going to explore next.
Thank you, Martin. And I do quite like the synergies between your presentation and Verity's presentation, which kind of finished, to my mind, for a call to action. There are a lot of complexities in some of the things that you talked about. It's a system that's had been challenged for some time, and we're sort of just seeing the outcome of long-term challenges in that system, and it's starting to crack and fail a little bit. But I hear hope, actually, in what you've presented, because you've plotted a really clear path forward and how we might think about that complexity. So thank you. Our final speaker is Dr. Michelle Morgan, Senior Policy Analyst at the Department of Premier and Cabinet, and recently awarded her PhD here at the University of Tasmania. Dr. Morgan has nearly 2 decades of experience in public policy and public health. Her research bridges academic evidence with real-world policy, with a focus on systems thinkings and wellbeing frameworks. She has played a key role in shaping initiatives at both state and local levels. Please welcome Dr. Michelle Morgan.
Thanks everyone for having me today. As Graham mentioned, I work at the Department of Premier and Cabinet, but this evening I'll be talking in my personal capacity and not on behalf of the government. So Verity spoke about what prevention is, and Martin spoke about the costs of prevention. And so now I'm going to talk about a systems approach to prevention. And the case that I'm making today is that staying well in a struggling system is not just a health policy issue, it's a systems issue. And that means it requires us to think differently, act collectively, and aim for a shared long-term goal. So let's start with thinking differently, and specifically from a systems perspective. So I'd like to invite you just to take a moment to have a think about what affects your health. So some of the factors you might have identified include eating well, staying active, or getting enough sleep. Others might include age, genetics, and gender. Others might include healthcare access and affordability. Others might include the quality of our personal relationships, work conditions, financial stability, and education levels. And finally, some of these factors may relate to where you live in terms of housing quality, the location of that housing, and access to services, having good water and air quality, and having access to nature and opportunities to participate in sport and recreation. So some of these factors can't be changed, such as our age or genetics, but many of them can. So this is a bit of a condensed version of some of what Verity mentioned. So when we think about all the factors that affect our health, it's clear that many of them occur outside the healthcare system. And in fact, it's been estimated that 89% of the factors that affect our health occur outside of medical care. Through our genetics and biology, individual behaviours, the physical environment, and our social circumstances. But what's most interesting about these factors is the interrelationships between them. And these relationships might be positive or negative or bidirectional. And the nature of these relationships will change over time. So none of these parts work in isolation, and action in one area might have ripple effects in other areas, which might be intentional or not. So just as an example, let's consider relationships between a few factors that affect our health. So on this diagram, we've got education influences both health literacy and income level. Health literacy influences health behaviours. Income level affects health behaviours, where we live and access to healthcare. Health behaviours and access to healthcare both contribute to better health outcomes. Health outcomes influences work productivity, and work productivity feeds back to increase income level. So this diagram is oversimplified, and there are many other factors and interrelationships between these factors that are missing. But just considering these few, we can see there's a reinforcing loop where improvements in education can lead to better health outcomes and higher productivity, which then supports higher income levels that can further improve health behaviours and healthcare access. So this type of systems thinking helps to visualise how improving education, as an example, can have a cascading positive effects throughout the web of factors that contribute to improved health outcomes. And that's not a single sector's responsibility, but requires coordinated action across multiple domains, from education policy to urban planning to healthcare delivery and workplace conditions, to create meaningful and sustainable improvements in population health. So this type of systems thinking recognises a system as a group of parts that work together to produce an outcome. So if we think about all the factors that contribute to our health, it's the relationship between all of those parts that produce health outcomes at an individual and population level. Systems thinking is a perspective that can help us see the big picture and understand how things are connected, so you can work towards desired outcomes more effectively. And there are many practices, tools, and methods that can help us do this. But when we don't think about the big picture, we might see problems as events or the tip of the iceberg. And the response is often to respond with fixes. So for example, a response to drug-related crime might be to deploy more police. A response to hospital waiting lists might be to deploy more doctors and nurses. A response to homelessness might be to build more shelters. A response to traffic congestion might be to build more roads. And while these solutions might provide short-term relief, the problems they aim to address are likely to return in the longer term, and the solution could actually make the problem worse. So we need to take a systems thinking approach to help us understand the big picture of complex issues and the interrelationships between the system parts, which will allow us to more effectively work towards the outcomes we desire. And what enables effective systems change is alignment across different sectors to work towards a common goal that reflects the outcomes we want to see. So generally, our societal goals are geared towards improvement in the economy, measured by gross domestic product or gross state product per capita. But as can be shown on this slide, while GDP has improved over time in Australia, happiness levels have declined. This demonstrates that GDP growth isn't delivering on all the outcomes we might actually want. So we need to think about a common goal that is broader than just economic success. And our recent experience of the COVID pandemic demonstrates that we can align towards a common goal other than wealth. When health and reducing impact on the healthcare system became a shared priority, we saw unprecedented coordination across sectors. Exactly the kind of systems thinking we need for other challenges. So what might an alternative system goal for Tasmania be? In Tasmania, we have the Tasmania Statement, and this statement, re-signed in January 2024, is a commitment from the Premier's Health and Wellbeing Advisory Council, of which Verity is chair, and the Tasmanian Government to work together with communities to improve the health and wellbeing of Tasmanians. This statement recognises the important role of the economy, but also the health and wellbeing of our people and the need to act on climate change for current and future generations. And for me, I think this statement is an ideal systems goal that, as a Tasmanian community, we should be striving for. And if we distill this statement to a phrase, it's about equitable wellbeing for current and future generations. And if we distill that further, it's about wellbeing, a commitment to work together to improve the wellbeing of all Tasmanians. And what I love about the concept of wellbeing is that it not only encompasses the concept of health, but also the determinants of health. And around the world, there's growing recognition that traditional measures of success, like economic growth alone, don't capture what matters most for well-being. So internationally, some examples include the Sustainable Development Goals and the OECD Better Life Index. At the national levels, some examples include Bhutan's Gross National Happiness Index. They have this in place of their GDP index. New Zealand has a Living Standards Index, and Wales has the Wellbeing of Future Generations Act. In Australia, we have the Measuring What Matters framework, which is a national wellbeing framework that tracks progress across social, economic, environmental and governance domains to provide a broader picture of Australia's wellbeing beyond traditional economic measures. So in Tasmania, we have several existing system-level policies that share a common purpose to enhance the wellbeing of Tasmanian people and place, such as the Healthy Tasmania Plan, the population policy, and the local government reform, which has recognised that wellbeing is a core part of local government's business. And what characterises these initiatives as systems level policies is that they recognise the interconnected nature of the social, economic and environmental challenges and take coordinated action across different levels of government and government departments and organisations to work towards better health outcomes. While these policies are striving for a common outcome, they each offer a different perspective and have different initiatives to work towards that common goal. So in addition, there are many more policies that work towards specific outcomes of wellbeing, such as those relating to healthcare, housing, jobs, and literacy. So while there's a lot of activity happening at different levels across government to improve people's wellbeing, working towards a common goal of wellbeing requires collective action across different scales. And collective action means different groups coming together, aligning efforts and sharing responsibility for outcomes. It's about collaboration, co-creating solutions, pooling resources, and building trust across boundaries. Actions towards a collective goal of wellbeing occur at different scales. At the individual level, this includes things such as our behaviours, our mindset, skills and knowledge, which might include something like walking instead of driving the car when possible, but it could also mean coordinating effort or advocating within your own community to respond to an issue. At the organisational level, it's about what workplaces and institutions do. How do they enable good health? Perhaps healthy catering policies or flexible work hours, or having access to secure bike parking. Then there's the community level. This is where neighbours, local groups and organisations come together. Community gardens are a great example of, so are walking groups and local sporting clubs. Then at the societal level, we have things like government policies and cultural norms. So this might include, for example, urban planning that creates walkable communities, food policies like providing nutritious food in schools, or economic policies like taxing unhealthy products like tobacco. And these different scales don't work in isolation. Changes at one level influence and support changes at all other levels. So for example, when a local government creates walkable or accessible neighbourhoods, it makes it easier for individuals to use active transport. When people in communities organise walking groups, it can shift social norms around being active. When workplaces offer flexible hours, it might provide people with the time they need to exercise. They all work together. So from within the system, I invite you to consider what parts you can influence or change to help shift towards a more healthy Tasmania, either at home, in your workplace or community group, or at a societal level. So you might not have an answer to these questions right away, but I invite you to take them away with you. So what action could you take in your everyday life, at home, at work, or in your community to contribute to better wellbeing for all? And to add a systems thinking lens, how might that action affect other parts of the system positively or negatively? And what change in response to that insight might you make to get a better outcome? Thank you.
Thank you very much, Michelle, for that introduction to systems thinking and how we might use that to think about the challenges that we face. While the speakers are walking over, I did want to reflect on the fact that we did start with a car analogy, and then Michelle described all of the ways that we should get out of our cars and get more exercise. I'm sure there's some irony buried in there that I haven't quite unpacked yet. And so if you have a question in the room, I ask you to raise your hand and one of our attendees will bring a microphone to you. While we're waiting for some questions in the room, there's an interesting question here from Sue online. And Martin, I might put this one to you because it's kind of a definitions piece around preventable deaths. There's a question from Sue about acceptable deaths, and do we report on that? And I wonder if there's an analogy we can draw from the Brian Johnson example that you used.
Okay, so acceptable deaths.
Yeah. What does an acceptable death look like?
Sure. Okay, so I mean, other than Brian Johnson and some of his mates in Silicon Valley, we probably all agree in this room that at this stage in human development, death is still an inevitable outcome for all of us. And so the question really is all about how long are we going to live, but also, of course, what is the quality of life and health that we're going to have along the way. So really, all of everything we've been talking about, prevention, all of everything that modern medicine has achieved has really been about both increasing lifespan, life expectancy, but also aiming to increase the quality of life as we extend those years. I mean, in terms of definitions, certainly health economics has spent a great deal of time on this question of, well, how do we measure that health-related quality of life? And some of the most ferocious debates in health economics are kind of angels on pinheads arguments about different measures that we could use to the outside observer that probably all look the same, but to us are, of course, deeply importantly different in minute ways. However, whether we're really increasing healthy life or whether we're increasing life expectancy but not necessarily increasing the healthy lifespan bit is still a very open question, partly because it's actually very hard to measure and get a grip on, but partly also because whilst life expectancy has continued to go up in recent years, and this is going back before COVID, in a lot of high-income countries, we're starting to see some quite negative trends in health, which are actually kind of interfering with what was previously seemed to be a fairly straightforward upwards progress. So I think I'm dodging the what is an acceptable death question slightly, but if we think about a preventable death, that's not, we cannot prevent death ultimately, but when we're talking about preventing death and preventable deaths, we're talking about a point in time where somebody did not need to die, and if we can intervene and do the right thing, whatever that might be, whether that's a preventive intervention or whether it's a piece of well-timed access to quality healthcare, we have stopped the person from dying at that point in time. The preventable hospitalizations come from different sources. Some of them come from acute sources, which is particularly things like injuries, so traffic accidents, violence, alcohol injuries, things like that. Quite a few of them are actually vaccine preventable. We haven't talked much about infectious disease today, but it's really important to never forget the centrality of vaccine preventable disease and the extraordinary effectiveness of vaccines. And the final area is the chronic disease preventable hospitalizations that Verity was talking about. So they're coming from different sources. And the problem, of course, is identifying who is about to have a potentially preventable hospitalization and doing what needs to be done. But it's a significant issue. I mean, I would say we will not prevent all disease ever. That is the nature of human life. We will not prevent all potentially preventable hospitalizations. Can we do better? Yes, and that's the objective.
Thank you, Martin. Question from the room?
Oh, I'd just like to say that I really enjoyed your analogy of putting good fuel into your car and keeping your car serviced. I don't see a lot of difference in the way we operate as humans in having a clean, healthy diet. We're having an excessively processed diet, and the negative consumption externalities are being foisted upon the government, and those reaping the rewards of the food manufacturers that are supported by government and not taxing giving leeways for sugar and so on. If you're a woman and your waist is over 80 centimetres and a man it's over 94, you've probably got some degree of metabolic dysfunction driven by, processed foods, excessive carbohydrates.
I'm wondering if we could pick up, we might pick up some of the points that you've made.
But basically, my question to you is, how would you drive that to make it more mainstream for people to have food choices where they're not influenced by advertising, by TV, by governments, by subsidising, the vegetable oils and the sugar and the.
So I might put the question to Verity then. So you mind if you can talk about the importance of access to healthy foods and nutrition in terms of driving preventative health, and might ask Michelle the follow-up question about how you might influence policy around that to incentivize or enhance those opportunities.
Yeah, sure. Thank you. And thanks for your comments. Yeah, clearly nutrition is one of the really key and common risk factors for many chronic diseases and conditions. And, we have something like only 5% of Australian adults meeting, recommendations for fruit and vegetable consumption, for example. I know there's a nutritionist in the room who might correct me on that exact stat, Holly, but I think I'm in the ballpark. And so, what do we do about that? And I think, again, referring to some of the things we've all spoken about tonight around systems, and in trying to ensure accessibility, availability, low cost access to the basics, like fruit and vegetables is really important. But then also looking beyond that too, you've mentioned taxation, and there's a lot of movement in some other parts of the world, taxes on sugar sweetened beverages, for example. Restrictions on unhealthy food advertising to children. So there are a number of different strategies at many different levels that I think, we could enact, but we haven't necessarily. So I think it would be great to see a bit more action in that area.
I guess just to add to what Verity said is changing food systems is really complex and it takes a long time. I think with the small amount of resources that are available for prevention to change the food systems, we've got nutritionists and public health food specialists who are doing what they can to change those food systems. I don't think I have much else to add to that.
Thank you, Michelle. I think they're both important perspectives on what is actually a really difficult challenge, and is kind of a systems challenge, isn't it? It's about people's self-efficacy in making choices, but it's also the systems that support those choices. There is a question here that I was actually posed to you, Verity, but I might pose it to you instead, Martin, because it speaks to your point around deregulation versus more regulation, and how that might be important, and the responses that some people get when they're trying to advocate for those things, and the response being, well, that would be a nanny state, or that would be a situation that would impact on people's freedom. So I'm wondering if you have a response to that.
Yes. Probably going to wish you hadn't asked that one, and I'll moderate the tirade. So I think it's very interesting. We have grown up, and I say that advisedly, as you know, this, what you might call the neoliberal revolution, was already well underway when I first started studying economics, and that was quite a long time ago. We've very much grown up with this idea that all regulation is potentially impacting on freedom, and that this is all about, as they would put it, as Isaiah Berlin would have put it, freedom from, versus, of course, the other way of thinking about freedom, which is freedom to. And really, in much of the sort of debate about those two different kinds of freedom, sees getting the right balance as essential. That absolutely we should be free from arbitrary interference by the state, but equally, sometimes things do need to be regulated to create the conditions that allow all of us to have the freedom to reach our potential. And when we're thinking about prevention of illness, it's hard to think of something which is more directly impacting on your potential to lead a good and full life than, for example, your life being cut short. So I think we really need to start moving out of some of that framing, not least because the argument about regulation as, you know, the nanny state impeding our freedom, we're not actually talking here about the models that people like Hayek and the apostles of those kind of freedom were ostensibly talking about, which is small businesses and entrepreneurs. We're talking about huge multinational oligopolies. I won't say monopolies, because very few of them really are monopolies, but they're oligopolists, who very small numbers of enormous firms who dominate most markets and have enormous power in those markets, not just power to set prices, but power to actually determine what they sell to whom, where, etc. And only one organization has the clout to stand up to those very large oligopolists, and that is governments, and national governments, really much more than states and territory governments in our case. So I think we do need to get to some rebalancing here, because the reality of how our economy operates is not at all like the kind of perfect competition model of billions of tiny firms. Yes, there are tens, hundreds of thousands of coffee shops, but how many supermarkets are there? We're talking about a very different model of the economy, where regulation and good policy is absolutely necessary to get the people the life opportunities that they require.
Thank you, Martin. I think we have a question from the room.
Thank you for the conversation. My question is about the rise of access to health data. Things like Apple Watches and other products are giving us more insight into our individual health metrics. I'm curious if the panel has any research or reflections to share on how this might impact the health system.
Yeah, possibly. Look, I think, personal sort of fitness tracking devices appeal to a certain sort of segment of the population. And for some people, they're really helpful. But others, not remotely interested, so they're not helpful. So I think it's really I guess, about ensuring that we, you know, one size fits all solution's not going to work. So if, you know, if there are people out there who are interested in, you know, monitoring all their things and going down Martin's friend Brian's path of, you know, doing all that tracking and spending all that time, and that works for them, I think, you know, that's fine. But I don't think it's a silver bullet in any way, because for many people that's not something they're interested in. And we know from you know, various health behaviour research that one of the you know, the biggest motivators is whether it's something you are interested in and enjoying. If you're enjoying being active, if you enjoy being well, you're much more likely to do it. It's the same with these sorts of things. If you enjoy them, you're likely to engage. If you don't, it's not going to work.
Thanks, Verity. We do have a question online from Fiona that talks, I suppose, a little bit about the issue of the political cycle and how short it is. And I might put a question actually to all three panelists, acknowledging that a lot of the things that we talked about have long time horizons and sit outside political cycles. But I also heard Martin in particular and others talk about things where you could get really short-term gains. So if you could pick one thing, you know, that would fit within a political cycle that you would influence or resource or change in the system, what would it be? I'm going to start with you, Michelle, down the end.
I think I would start on by looking at ways of working across government and community, looking at the structures, collaborating across political parties and communities, I guess, to set that agreement towards the common goal. Collaborating and working together and crossing those boundaries takes time, and it takes time to build trust. So I think that when we're working on these complex issues, allowing time to build those relationships to work like how we work together.
So you're sort of talking about setting a collective vision that everyone owns, irrespective of their, you know, political flavour or that sort of thing. So I think I agree. I think that's a really, really important point. Martin, did you have a view on that? The one thing? I'm sorry for restricting you to the one thing.
So the one thing, fine. The one thing I do is go straight to really massive investment in enhanced public transport, because I think that delivers so many benefits across so many dimensions of health and other social well-being. And as I was saying, you know, we have areas in this state which have very poor air quality. A big contributor to which is road traffic. And I think really intelligent, really ambitious thinking about public transport, electrification, etc., could have really quite surprisingly quick impacts on health, but also just huge multipliers on lots of other social benefits.
Thanks for sharing that perspective. Verity?
Well, those two both just stole my answers, and I wholeheartedly agree with both of them, but I'll pose a different suggestion, although I'm not convinced that it's a short term, but my focus would be on education. And I'm not talking about running education programs for people that are already well. I'm talking about schools and getting, you know, particularly in Tasmania, our completion rates up and encouraging greater tertiary education. I think that's going to be such a huge, well, it is a huge driver of health and wellbeing, is our level of educational attainment. So, yeah, maybe controversial of me as a health researcher, but I would suggest directing those resources towards education.
Thank you. Do we have some questions in the room?
We'd expect that if there were more demand for the sort of ideas you're discussing tonight from the general public, that would be a stimulus for political action, which is really what's required. Now, ideally, how would you see health literacy in the wider community being improved, let's say?
So the question was about health literacy. May I start with you on that one, Verity?
Yeah, I can have a go. And I know we have a health literacy expert in the audience. Hello, Rosie. So I feel like deferring to you. But I think perhaps part of your point also goes to the narrative around prevention. It's not talked about a lot. It doesn't get a lot of publicity or airspace or airtime. And part of that is, I always think, because you can't see prevention. It often happens through policy or environmental changes. And we don't see someone not getting sick. So we see people getting sick, we see ambulances at the hospital, whatever, but we don't see it when we don't get sick because of things we did a long time ago. And so I think we don't talk a lot about prevention, and it's not high on that radar because of that. We don't see that benefit. It's nearly an invisible benefit. So I don't know if that fully answers your question. But I think all of us have a role in shaping the narrative in the community. And I guess that's why we have events like this to speak to people about the importance of prevention. And I know at Menzies, we have it as one of our 5 key focus areas is prevention. We continue to support the state government in their initiatives around a preventive health strategy. So yeah, let's keep talking about it. And I think you're exactly right. When communities demand change, that's when we may start to see something.
Thank you, Verity. We are very rapidly approaching the end of our time tonight. We have time for one more question. So might go to an online question. And this actually touches on, I suspect, a number of the talks that we've heard tonight. And it's about this idea of ineffective care as well. And how do we manage people's expectations around care and align that with the wanting to avoid ineffective care. You have a response to that one, Martin? Probably sits mostly aligned with your presentation.
Yeah, so that is this question of what is often called low value care, which is care that will provide only minimal or potentially no benefit to people. It's quite a significant problem, certainly. It's slippery to get a real handle on it, but many healthcare systems in high-income countries, the estimates are that maybe between 10 and 20% of care is potentially low value, not really delivering significant benefits to people. How do you deal with it? You start first with healthcare professionals, with doctors, nurses, etc., the people who are delivering this care, and being really clear with them about educating people as research comes out, as we see whether something is or isn't effective, making sure they have access to that information. But we also need to be reasonably assertive in what we will fund in the public healthcare system and through Medicare. And if something is really low value and really not effective, we shouldn't be funding it. And some good steps have been taken in that direction over the last few years, but it's tricky. And again, it's tricky because it's very hard to find interventions which are uniformly useless. Most interventions probably will benefit somebody somewhere. The problem is, will they actually benefit the person in front of you? But yeah, it's can be a sensitive area, of course, because people are usually doing these interventions in good faith. But it requires action on lots of fronts, including financial incentives, but also very much professional kind of standards and how people view what is good clinical practice.
Thank you for that response, Martin. Sadly, that does bring us to the end of tonight's conversation. I really want to thank everyone for your engagement. There were a number of questions that unfortunately we didn't have time to get to. Finally, and last but absolutely not least, please join me in once again thanking Professor Verity Cleland, Professor Martin Henscher, and Dr. Michelle Morgan for sharing their expertise with us tonight. Thank you all for taking part in tonight's conversation. On behalf of the University of Tasmania, have a happy and safe evening. Good night. Travel safe. Thank you.